Good evening. I do want to apologize before I get started. My camera is not working for me right now, so I will be off camera. But the show must go on. Welcome everyone to the Louisiana Campaign for Tobacco-Free Living's Empowering People Community Series. Today's webinar is HIV and Tobacco Dual Challenges in Health Equity. Again, welcome. About TFL's Empowering People in Community Series. The mission is to equitably bringing health, education, resources, and hope to people, populations, and communities in Louisiana. Our learning objectives for today: one will describe the intersections of HIV, tobacco use, and cancer, including how these factors affect health outcomes, particularly in underserved communities. Identify key social and clinical interventions for HIV prevention, care, and treatment with insights for case studies and common research. Analyze the role of tobacco use in cancer development and its impact on HIV-related malignancies, emphasizing best practices for prevention and patient support. Lastly, we'll discuss evidence-based approaches and policy frameworks for improving health equity in HIV, cancer, and tobacco prevention among high-risk populations. And I will be your moderator and also your second speaker for today. My name is Michelle Oza. I'm the Social and Health Disparity Senior Coordinator for the Louisiana Campaign for Tobacco-Free Living, which is a program of the Louisiana Cancer Research Center and the Louisiana Public Health Institute. Now we'll move on to our first speaker. We have Mr. Jack Holder. He's the HIV Service Manager for Crescent Care, and he will get us started.
Great. Thanks, Michelle. First, I just want to thank you, Michelle, for hosting this webinar, especially on today on World AIDS Day, a day that we are dedicated globally to remembering and celebrating the lives of people who have died of AIDS and AIDS-related illnesses. It's a very important day in our work and my work, and a day that our government is choosing this year not to recognize. So it's more important than ever that we are doing events like this. So my name is Jack Hoda. Like Michelle said, I am HIV Services Manager at Crescent Care. And in that role, I'm kind of the project coordinator across our entire organization of all of our HIV related programs and grant funding sources. So predominantly that's federal government funding from the Ryan White program, which I'll talk about a little bit during my presentation, but also any other private or state or local grants that we receive to do HIV related work. So at Crescent Care, we are currently a federally qualified community health center providing primary care, behavioral health, oral health, case management, a whole host of services across the New Orleans metropolitan area. But we started as a No AIDS task force in the 80s, specifically an HIV service organization, mostly run by volunteers to start, and provided case management, social support, for people living with HIV in the area. And we have just grown since then to do prevention work, primary care, food pantry, medical transportation, and on the list goes, to where we are now serving more than 13,000 patients a year, and just doing the work in the community. So that is me, and that is Crescent Care. But I'd love to go on to the next slide and get into my portion of the presentation. I will be kind of doing a bit of an HIV 101, a very brief HIV 101, because most folks on here might be very familiar with this stuff, might not, but it's very important to all be using the same language and concepts when we get into topics like this, and talking a little bit about kind of the HIV policy landscape that we're facing right now, that has impacts on our work, on people living with HIV, and especially on the intersections here that we're going to be talking about with tobacco use. So we can go on to the next slide. So I'll start with just some key terminology, just so we're all using the same language, and same concepts. So HIV obviously stands for human immunodeficiency virus, and that is a retrovirus that attacks the immune system. Um, HIV is different from AIDS. So you see also here acquired immunodeficiency syndrome, which is AIDS, which is kind of the advanced form of HIV. HIV is often talked about in three stages these days. So stage one would be the acute infection when someone um, acquires HIV and has really intense symptoms. Stage two would be chronic HIV, which is what most people are just living with HIV in their daily lives. It's a manageable chronic illness at this point. And then stage three would be the clinical term AIDS for when someone's CD4 count falls below 200. And so the CD4, which is that second bullet, um, the CD4 T lymphocytes or T helper cells are our immune cells that help kind of um, facilitate our immune system. So the HIV virus hijacks these cells and attacks and kills them, and that's how HIV multiplies and spreads. So the last term that you'll see on here is viral load. This is one of the most important regular common blood tests that folks living with HIV are getting on a regular basis. And the viral load measures the number of copies of HIV genetic material in a volume of blood, and really can be used to measure kind of how contagious someone would be. So we can go to the next slide and talk a little bit more about treatment, viral load, and adherence. So antiretroviral, ARV, often we'll see this as ART, which is a combination of ARVs, and antiretroviral therapy is a treatment used to treat HIV. Medication adherence is very important with HIV treatment. It's very important that folks living with HIV consistently take their medications as prescribed, because when we do that, folks living with HIV can have an undetectable viral load. So you may have heard of U equals U or undetectable equals untransmittable. And this is when the viral load is so low in someone's blood that it can't be detected on a test. That also means that HIV cannot be transmitted to another person through condomless sex, which is an amazing, amazing advancement in HIV science. And has been proven in many studies, studying thousands of what are called serodiscordant couples or couples that include someone living with HIV and someone without. So this evidence is really, really strong, and is one of our kind of core tenets in the ending the HIV epidemic plan, known as treatment as prevention, right? So when people are on treatment, are undetectable, cannot transmit HIV to others, that is one of our best prevention tools in preventing the spread of HIV. We can move on to the next slide. So now I want to talk a bit about HIV epidemiology, a very, very high level overview. So the information on this slide comes from the CDC, and they do a lot of modeling and estimations around HIV in the United States. So this slide shows that in 2022, an estimated 1.2 million people living with HIV in the US, and for every 100 people living with HIV, only 87 knew their status. So the CDC uses modeling to identify gaps in where people living with HIV may not have been tested or may not know their status. And so this is a core gap that we're trying to address in the Ending the HIV Epidemic program, which I'll talk a bit more about later. We can go on to the next slide. So this graph I'll talk through a little bit because the key got cut off of the graph. But this shows kind of trends in the HIV epidemic since the start through to 2015. So obviously in 1981, the start of the epidemic, you see these three lines that are modeling three things. The solid dark blue line is showing us HIV incidence or HIV diagnosis rates. The light blue dotted line is showing us AIDS-related deaths, and the solid green line is showing us HIV prevalence. So as we're seeing it go up from 1981 to on to 1995 is around the time that the first HIV treatments were developed, or the cocktails as they were called. And so you see a pretty sharp decrease in both HIV incidence and AIDS-related deaths. So a big advancement. These treatments have obviously gotten better and better over the years. But one thing that's really important for us to know in the HIV field right now, and also is a big intersection with tobacco use and the effects of tobacco use, is that the majority of people living with HIV today in the United States are 50 and older. So a lot of folks were on those initial treatments that had some really intense side effects and have today even long-term side effects that folks are dealing with as they age. And then you'll notice that the green line for HIV prevalence rate or numbers of people living with HIV continues to rise because of the advancement in our treatments that are ensuring that people live long, healthy lives with HIV. So we'll continue to see that number rise. We can go to the next slide. So this chart shows a kind of overview of demographic data of folks living with HIV in the United States. So a lot of this is pretty standard in kind of the HIV literature and conversations about HIV, but the majority of folks living with HIV in the United States are biologically men or cisgender men, and the age range kind of varies, but we're seeing a really kind of gradual rise in folks that are aging with HIV, so that 55 plus age range. You definitely see disparities in race among folks living with HIV. So really high rates of Black and African American and Hispanic or Latino folks living with HIV, even though they don't make up nearly as much of a percentage of the US population. So those disparities are very real and also reflected when you look at the region of residence. So the majority of people living with HIV in the country live in the South. And so we see a lot of intersections there with race, with rurality or living in rural areas, and income level as well. So we can go to the next slide. This map kind of shows that information about regionality transposed and shows those prevalence rates. And so I think it's really important to see the darkest colored states are the ones with the highest prevalence rates. And so you see a lot of southern states are in that list, especially Louisiana, which we see has a pretty high rate of folks living with HIV. We can go to the next slide. So I want to talk a little bit about myths versus facts with HIV. I think one of the biggest areas of myths and facts is the way HIV is transmitted. And this really contributes to stigma that folks living with HIV and working in HIV and in healthcare in general are really dealing with. So the only ways that HIV can be transmitted is through blood, semen, vaginal fluid, and breast milk. It cannot be transmitted by air or water, by sweat, saliva, tears, urine, insect or tick bites, or and especially not shared utensils or shared toilets. A lot of folks who are newly diagnosed with HIV experience these interactions with friends and family and community members that have misconceptions about how HIV can be spread. And this creates really stigmatizing experiences for people within their community, can be very isolating, can prevent people from wanting to seek treatment, to be open about their status, and just contributes to the factors that persist the epidemic, prevent testing, prevent treatment, prevent education, right? So we can go to the next slide. So the HIV care continuum, this is kind of our roadmap for getting folks into care and maintained in care. Starts obviously with diagnosis. And from here, it's not really displayed on the slide, but the goal from diagnosis is also kind of a status neutral approach. So you see both the positive and a negative on that little hexagon. So the goal would be folks who test positive are immediately linked to care for HIV treatment, and folks who test negative are immediately linked to treatment for PrEP or HIV prevention if that is necessary and indicated for them, right? At Crescent Care, I think we do this really well. We have a rapid start program that we call the Crescent Care Start Initiative, or CCSI. And so when folks are identified as newly diagnosed with HIV, either through our programs or community partners or outreach testing, we have a linkage coordination team that gets them connected into HIV care within 72 hours of that diagnosis. And so the goal is to get folks the resources they need as quickly as possible, to talk to folks about the misconceptions they might have about HIV, to make sure that they're in a good space to begin treatment. And most folks actually start treatment in the doctor's visit with the provider on that first visit. And so the goal there is immediate linkage to care and initiation of treatment so that folks can get undetectable as soon as possible. Right? That treatment as prevention approach means that the sooner that someone is undetectable, the less time that they can potentially pass HIV to another person, right? Once we've gotten folks engaged in care, receiving treatment, gotten to an undetectable status, the goal is retention and care. And that's a big focus for us right now, nationally in all of our programs. And the key here is that the really vast community of folks living with HIV are a really diverse community, right? Facing a lot of different social determinants of health, a lot of different intersecting barriers to care. Um, and so the goal here is to really think about who are the populations we're serving, what do they need to have addressed to make sure that their medical care and treatment can be a priority, and what are the barriers that we can help eliminate to help them achieve that. And so once that is addressed, we can hopefully achieve and maintain viral suppression and keep people engaged in that treatment cycle, um, and prevent further transmissions, right? And also address comorbidities and other intersecting illnesses that folks are experiencing as they age, which is another kind of core topic of today with those intersections of HIV and tobacco use. So we can go on to the next slide. So a little bit about kind of the holistic HIV care system in the United States. I've talked a little bit about the Ryan White program earlier. But the Ryan White HIV/AIDS program is a national program that was passed by Congress in 1990 that established this program managed by HRSA as the payer of last resort for low-income and uninsured people living with HIV across the country. So at this time, most folks living with HIV did not have health insurance coverage. There were exclusions for pre-existing conditions that meant folks with HIV could not get private health insurance generally. To get Medicaid access, you generally had to be having your disease so advanced that you qualified as disabled. So at that point, folks were already in really dire circumstances, and it was also very expensive on the care system. So Ryan White created a backbone for the HIV care system that saved lives. So in 2023, the program across the country served more than 500,000 people living with HIV in the United States and achieved a 91% viral suppression rate, which was a huge success. The first time that nationally we'd been over 90% viral suppression. And also, it's a huge increase from 2010, before the passage of the Affordable Care Act, or before the implementation of the Affordable Care Act, which was at, I think, about 64% viral suppression, and is also much better than the national average that includes all people seen outside of the Ryan White care system, that's about 65% right now. So definitely shows that the Ryan White program has huge impact, and is incredibly beneficial to the community of folks living with HIV in the US. So we can move on to the next slide. So, talked a bit about terminology, HIV epidemiology, the care system, but I also want us to really be thinking about, especially today, um, what are the challenges that we are facing right now and in the coming 2 to 3 years in the current public health landscape. The Ryan White program is an amazing program. It serves obviously over 500,000 people, um, and has really great health outcomes. But the Ryan White program is not the only resource for people living with HIV. And so I think that getting that holistic picture of what all of these coverage systems that kind of overlap each other and intersect with each other um, look like is important for us to know going into a phase of really rapid and intense policy changes. So first, want to think about international funding cuts. So at the start of this administration earlier this year, there was pretty immediately a pause on both international and domestic humanitarian programs, right? So that included all of our global HIV programs like PEPFAR and USAID, but also domestic programs. So Ryan White programs experienced that pause too, and there was a few days where we at Crescent Care were worried if we were going to be able to even continue services. That domestic pause was pretty immediately lifted because of public outcry and a lot of pressure from a lot of public officials. But the global pause lasted a lot longer, included a lot of cuts to grants and also the dismantling of USAID that administered a lot of those programs. So even when programs were re-implemented, the system and infrastructure in place to get funding out the door and support program recipients in other countries was not there. So UNAIDS actually published a report recently estimating that because of these funding cuts, that we will see an additional estimated 6 million HIV transmissions globally and an additional 4 million, that slide specific 4 million, not 4, AIDS-related deaths by 2029, which is a huge setback given the progress that we've made. I've talked a lot about the US over the past 30 years, but globally, we've made a ton of progress in the HIV epidemic and towards ending the epidemic. So this puts us back. And even though this is global programming, this is programming going to other countries and funding going to other countries. Epidemics are a domino effect. I mean, we saw that in COVID, right? So when we see increase in transmissions and decrease in people on treatment and then decrease of people who are undetectable, that impact is not going to be contained to a single country. That is going to spread, right? So more domestically. Also, the Department of Health and Human Services released budget proposals this year. Some were leaked proposals, some were actually published by them, but proposing eliminating all of the HIV prevention funding in the CDC, which funds organizations like Crescent Care and other organizations across the country, and also health departments to do HIV testing and education programs, um, and PrEP as well. And so the administration has proposed eliminating that in fiscal year 2026, and also Part F of the Ryan White program. So Part F of the Ryan White program is specifically workforce development. So that funds uh, education and trainings just like this for the HIV workforce to stay up to date on changing recommendations, on updated medications and program interventions that can help us all improve across the country. So that would be really detrimental to the Ryan White care system. Additionally, the Congress this year proposed a number of obviously different kinds of appropriations proposals, but there was one specific appropriation bill that was proposed and did not eventually pass, but did propose cutting the Ryan White program in half. So not just the Part F program. This goes farther than what the administration was proposing to cut Ryan White Part C and D, which are different programs within Ryan White that provide grants directly to community-based organizations like Crescent Care and other organizations throughout the state and country to do direct HIV care, treatment, and support services. So that would be a devastating cut as well. This appropriation proposal also proposed eliminating the CDC HIV prevention funding, like the administration did, but also proposed eliminating the Ending the HIV Epidemic Initiative, which, if you've never heard about that before, is a national program that was actually spearheaded by the first Trump administration and passed in 2019 that has really kind of focused on and targeted very high impact areas throughout the country that are heavily impacted by HIV to funnel kind of flexible spending funding to do innovation projects to try and address the public health needs in the HIV landscape in those areas. And so that was passed in 2019, right before the COVID pandemic. The program got off to a bit of a shaky start because of that. But the HRSA and CDC have attributed a lot of really strong gains over the past few years to the EHE initiative. But despite that, the same administration or previous administration that spearheaded this program is proposing eliminating it now. And then outside of programs that are specific to HIV, the health coverage landscape in general is really important to be considering because, once the Affordable Care Act passed and expanded Medicaid in many states and also created the healthcare marketplaces with enhanced premium tax credits that made them more affordable and instituted all of these requirements on health insurance companies to participate, really opened up access for people living with HIV to health insurance coverage that the community never experienced before. So elimination of pre-existing conditions considerations for coverage allowed people with HIV to get health insurance. The ACA marketplace plans have some requirements that HIV treatments be covered. The premium tax credits allow people to afford it. And the expansion of Medicaid opened up Medicaid coverage to a lot of people who would not have been previously eligible. So a lot of coverage for folks who were previously relying fully on Ryan White funding. And that both opened up a lot more access for people to access, emergency room, hospital specialized treatments that Ryan White funding is not allowed to cover. But it also allowed Ryan White programs and states with Ryan White funding for HIV treatment to really kind of stretch their dollars and do more support services, addressing social determinants of health. And also, a lot of these programs now cover health insurance coverage for clients. So clients don't have to come out of pocket for their health insurance through these ACA plans, and they can have expanded coverage, and it saves so much funding for the Ryan White program to focus on other areas. All of that whole system is really under threat right now because the One Big Beautiful Bill Act that passed this year is estimated to cut millions of people off Medicaid over the next 10 years. And also this year, the Affordable Care Act enhanced premium tax credits are set to expire. That's what the whole government shutdown was over this year. And we came out of the shutdown with no solution to the expiration of those tax credits and still don't have one. So with all of these changes to the health coverage landscape that are happening right now, starting in January, we could have a very different landscape, not just for the programs that serve people living with HIV, but also for people living with HIV and what they can and can't access and can and can't afford. So that is a bit of a dire landscape that we're facing right now, but it's important that we know what we're up against, and know kind of how to navigate the system and the changes that we're seeing, and understand kind of what those implications can be, not just for folks in their HIV treatment, but what other treatments they're able to access, like tobacco cessation, cancer treatment, etc. So that really covers my portion of the presentation. So I will hand it over to Michelle, and we can dive in more to those intersections of HIV and tobacco.
Thank you, Jack. Again, I am Michelle Oza. I am the TFL Social Health Disparity Senior Coordinator. And again, I just want to apologize. My camera is not working, so I'm not on camera today. But I will be providing the correlation between HIV or people living with HIV and smoking. So, smoking prevalence among people living with HIV are higher. The smoking rates are 2 to 3 times higher among people living with HIV compared to the general population. This disparity is driven by factors such as mental health, substance use, social stressors, and structural inequalities. Smoking and HIV. Some stats are smoking has been associated with nearly 500,000 deaths annually. Secondhand smoke has contributed to over 41,000 deaths, and this is annually as well. Cigarette smoking is known to cause serious health consequences such as chronic obstructive pulmonary disease, or COPD, cardiovascular disease, cancer such as lung, head, neck, cervix, insulin resistance, metabolic syndrome, and diabetes. HIV and AIDS increase the likelihood of non-HIV related cancers due to immune suppression and inflammatory processes. And the immune suppressive effect of HIV and AIDS and smoking might make some conditions more likely, such as thrush, which is a mouth infection, hairy leukopenia, white mouth sores, bacteria, pneumonia, just to name a few. The impact on HIV disease progression. Tobacco accelerates the immune suppression and worsens the viral load of outcomes. Basically, it's giving you more load, more stresses to the normal organ functions in your body. It's also smoking is also linked to poor ART, as Jack mentioned earlier. It worsens just your whole breathing and just being able for your lungs to breathe in the air in and out, and just makes it a little harder to breathe mostly, and then it makes it harder to actually live with the actual HIV and smoking. So it's kind of a, if you think of it, it's kind of like a double negative. Increased risk of HIV associated cancers. Tobacco use greatly increases the risk of both AIDS defining cancers such as non-Hodgkin's lymphoma and non-AIDS defining cancers such as lung, head, and neck, cervical, and more. Among people living with HIV, lung cancer risk is especially high, often surpassing traditional AIDS-related complications as a cause of death. Cardiovascular and pulmonary complications. HIV infection itself increases cardiovascular risk through inflammation and immune activation. Smoking compounds this by leading to higher rates of myocardial infarction, stroke, and chronic obstruction pulmonary disease, or COPD. And also people that live with HIV who smoke develop COPD at a much younger age than the general public and with greater severity. The mortality of someone living with HIV and smoking, um, it smoking contributes more to mortality in people living with HIV than HIV itself. In some cohorts, a large Danish cohort study showed that the life expectancy loss from smoking exceeded that from HIV infection if ART was effective. Cessation and intervention opportunities. Smoking cessation has immediate health benefits. As soon as you stop smoking, first 5 minutes, you can see a lot of noticing in the body, especially with breathing, especially with coughing, just inhaling, maybe even walking, but you notice when you first started quitting instant changes within the first 5-15 minutes than what it was before. Um, Also, people living with HIV face barriers such as high nicotine dependence, mental health challenges, and competing health priorities. For the most part, again, it's a double negative. If you are a smoker and you're a person living with HIV, it does not help the immune system either one. Not saying that, not putting in the words of like you can't get over smoking, but if you're doing it, it just makes your immune system even more worse because it'll be hard for you to be able to function and be able to do more that you want to do, and it kind of prevents you to becoming more healthier or being able to live with HIV. So, in conclusion, to wrap up, people living with HIV are urgently needed to reduce this dual burden of disease. Tobacco use among people living with HIV is significantly higher than in the general population. Smoking worsens HIV prognosis, reduces ART effectiveness, increases risk of both AIDS-defining and non-AIDS cancers, especially lung cancer, elevates cardiovascular and pulmonary complications, and shortens life expectancy. Interventions tailored for people living with HIV. With that, I know we gave you all a lot of information. If anyone has any questions, please put in the chat or in the Q&A section. I do have a few questions for Jack to answer for us. If I can find it. All right. So my first question that I have is, from your experience at Crescent Care, what are the biggest barriers people living with HIV face when trying to quit smoking, and how can providers better support them?
Thanks. Yeah, I think the biggest barrier that we see is obviously it's an addictive substance. And so there's a very just real kind of addictive process that's hard to overcome. And so the kind of reliance on behavioral health support is very important. I think very often providers have so much to address with a patient when they're working with them and have such limited time that often it's just a such a short conversation about tobacco cessation when um, they're really in a place like Crescent Care and a community health center that's whole person focused. You have the opportunity to loop in a behavioral health therapist or referral for some sort of support there. There are recovery support groups that can be connected with, um, especially for our clients living with HIV. They can be connected with their case managers for additional support to address other needs that they have that can help with facilitating tobacco cessation. So um, I think there are lots of different strategies that folks can take to help overcome those barriers. But it depends on obviously the patient or person and the things that they're facing, and also the supports that the provider has access to.
Okay, thank you. Um, Another question, I don't see in the chat. What policy or community level changes do you believe will make the greatest impact in reducing tobacco-related cancer disparities among people living with HIV in Louisiana?
I think just a greater investment, right? A greater investment not only in, HIV services, but also in tobacco cessation programs um, and treatments. Um, in that same vein, not, we rely on grant funding and financial support, but also more education and training for our providers and care teams that are helping folks overcome these challenges.
Yeah, I agree. Agree with that statement. I know it's a challenge for everybody. I know even like for us with cessation, resources, just trying to be able to keep that service free. Those of you that are on this call that are interested in trying to quit, we have numerous ways to quit of calling 1-800-QUIT now, going to quitwithus.org. There's the text to quit, there's a text app, or even for the youth that vape, and just making sure to have the resources out there because a lot of people are going through different things. And I know sometimes, different people handle their stresses or anxieties in different ways. Some people like to self-medicate, some people don't. But just understanding like there is support out there. There's somebody to help you with whatever you have going on. And even though in this current political climate, we're still here, we're still doing the best that we can with what we have. Just always reminding people that we still have the free services that we can do if it's available. And keep going. My next question is, in your work, how do social determinants such as housing, instability, stigma, or mental health affect tobacco use patterns among people living with HIV?
First, I just wanted to say thank you for sharing those resources that y'all provide because that's something I didn't touch on, but obviously not everyone is ready to have a conversation about tobacco cessation with their doctor or with their care team. And so having those resources they can reach out to on their own is very important to have, a diverse range of tools in the toolkit for everyone that's in their different situations. So thanks for sharing that. Um, but on the social determinants question, there's so much, especially, for the community of folks living with HIV. I talked a little bit about, just the disparities that we see in the community of folks living with HIV. And so that's just exacerbated when you think about addiction and substance use. When folks do not have stable housing, they're more susceptible to substance use, and that's really um, uh, very prevalent in the community of folks that we serve here in New Orleans, right? We've kind of invested a lot at Crescent Care in not just being kind of a medical care center for HIV and primary care, but also integrating that with substance use and services for folks who are unhoused. In our prevention department, we have a program called NOSAP, the New Orleans Syringe Access Program. And so it's a syringe exchange service um, operated out of our prevention program, which is kind of set off to the side of our clinical space so that folks don't have to kind of go through a clinic waiting room or anything like that to go through the syringe service program. They have kind of their own interests that's more accessible and kind of low stakes. But it's also not just a syringe exchange program, it's also a connection into services. So we have a full-time provider that's stationed in our prevention department. We call it the Prevention Access Clinic. So as folks are coming in, if they indicate that they are interested in some sort of substance use treatment, they can get connected to the provider right then. If they're interested in STI testing, um, and need to be linked to some sort of care or prevention service, like that provider can step in those cases. And so just trying to kind of meet people at multiple points of entry, addressing the needs that we can in the moment that we can, because obviously recovery is a long process for most people. It's not something that you can address in one visit. And so addressing the things that we can address in one or two visits helps us kind of get to the point of the recovery journey, right?
Okay. Yeah. All right. I have two more questions for you. I don't see any in the chat. All right. So my next one is, how does tobacco use biologically and behaviorally increase cancer risk among people living with HIV, even when they are virally suppressed?
I think preface that I'm not a clinical provider. So this
Mhm.
is not medical advice, but I think one, HIV attacks the immune system. So folks living with HIV even folks who have been undetectable for a very long time uh, already have a more suppressed immune system than the average person. And so any kind of practice or environmental factor that's a contributor or potential contributor to cancer risk is going to have a heightened impact on folks living with HIV. So being virally suppressed is the best thing that we can, or one of the best things we can do to prevent that. You know, cessation would be the number one best thing to prevent that. But when folks do struggle with medication adherence, when folks, um, one thing I didn't really talk about in medication adherence, but when folks are on and off medications and not taking them consistently, there's a risk that folks can develop resistance to their HIV treatment. And so once that happens, um, the treatment process becomes more complicated, and more expensive and less effective. And so folks in that situation, um, where their viral load is uncontrolled, right, then they are um, on a path to a more suppressed, more damaged immune system that just increases that cancer risk. So I think, I mean, HIV treatment and viral suppression or having an undetectable viral load has already been shown to decrease cancer risk. Because I mean, one of the kind of leading co-infections or um, comorbidities of folks with AIDS is Kaposi sarcomas, which is a cancer, right? And so we've seen a huge decrease in incidence of that um, because of HIV treatment. So it obviously has a major impact. Um, but the intersection is really important.
Thank you. And then the last question is, what successful strategies or interventions has Crescent Care implemented to integrate tobacco cessation into HIV primary care or case management?
Yes, we have a health education team that does smoking cessation sessions with folks outside of like the visit with the provider. We also, do, all the different kind of forms of medication assisted cessation. We have a behavioral health team that can provide that mental health support during the process. So I think we provide, the traditional approaches, the approaches that we know are effective. Um, and I think the biggest thing that we have in terms of additional support for our folks living with HIV is that we do have dedicated resources for folks living with HIV, like our case management programs are predominantly focused on folks living with HIV and some additional support services that we provide through Brian White, like some food assistance and some housing assistance programs and things like that. Can help with addressing the social determinants of health, specifically in the community of folks living with HIV that can be barriers.
Okay. I just want to add, just kind of reiterate the free services we have with quitwithus.org. We have those services and it's anonymous. They take your information, of course, the regular demographic information to know who you are, and then they also tailor your needs to what you like. So some people might want to coach and they want to talk to some people. Some people might just want to text, like they just need encouragement that day or something. There's plenty of different ways to help. Just want to add that if you go through Crescent Care, you also have this as an additional resource if it's something that you need right then and there. There's a bunch of options that's offered to you. We have a question in the chat. It says, how can smoking cessation advocacy and policy better incorporate HIV/AIDS awareness, increase access to resources, since diagnosed individuals are more likely to cope with or use substances such as tobacco?
That's a great question. I think the more that we can all do in terms of, I mean, not just in the HIV space and tobacco cessation space, but all of these public health spaces that share overlapping, populations and barriers, um, is share our resources together, right? I think like this conversation we're having tonight is a really important part of that, having these shared training spaces, but also having, resource lists for your program participants, for your clients that can be relevant to the resources they need. So Crescent Care has an amazing HIV services program, but we're also not the only HIV services program in New Orleans. So if you're serving folks in New Orleans, um, we have a city Ryan White office that has a whole list of HIV resources in the city that serve different areas of the city or have different service types that they can provide. And so having those resources available for your clientele is really important too. Um, so I think, having these shared spaces where we're sharing knowledge, having shared resources that we can kind of cross-pollinate our programs with, are big helps.
And I'll just add to that, and the follow-up email that will also have the survey, which I also talk about when we're done this part. We will have the, oh, sorry. We will have the resources of saying what TFL has and then what Crescent Care has, and then you can also have Jack's email. I'm pretty sure it'll be fine to share, but it'll be like his email and then just Crescent Care's address, the information if y'all want to contact them. All right. That's all the questions I have. I don't see any more questions in the chat, so moving right along. Uh-oh. Surveys. So those of you that attended this webinar, there was a misprint on the CEU is for an hour and a half. The webinar was actually 5 to 6:30, but we're wrapping up 30 minutes early. But you will still get your hour and a half for social work. We did not offer chess this time, but we did offer social work CEU. So in the follow-up email, you'll see that survey link. Please answer the survey link. Even if you're not getting the CEU credit, just let us know how did you like this webinar, if something needed to change. Just giving us your feedback. The recording will be live, will live on YouTube on our YouTube channel, which will also be in the follow-up email that will be sent to you. So if you want to share this resource of this webinar, you can as well. Want to thank Jack again. Thank you for doing this webinar with me tonight. Thank you for your time and patience dealing with me over these planning parts of it all. I really appreciate you. And with that, I will give it back to Jack if you'd like to say the last few words, and then I will close us out.
Thank you so much for having me. Thank you for your questions. And I look forward to working with y'all more in the future.
Yes, same. Thank you. Y'all have a good night. Stay warm.